Hi, I'm Tony Pisani. The program you'll hear about today resulted from a partnership between Safeside Prevention and a large youth services organization called the Hillside Family of Agencies. Dr. Sarah Donovan from Safeside, who'll take my place here in a minute, and Dr. Laura Majuli from Hillside will present evaluation data, including initial results from Australia and New Zealand, where a growing number of youth organizations are partnering with Safeside. One person who isn't here today, but I need to mention, is Christina Mossgraber. Christina is a close collaborator with lived experience, and she was incredibly important in this work and the adaptation every step of the way.
Hi, I'm Sarah Donovan, Director of Learning Transfer and Sustainability for Safeside Prevention.
And I'm Laura Majuli, Director of Research for Hillside. Hillside's a large nonprofit human service organization in Rochester, New York, in the United States.
Today, we'll walk through this project, including how we adapted sustainable approach to workforce education and suicide prevention for youth services, and then implemented and evaluated it across Hillside. We'll share some preliminary data from our ongoing evaluation of the adaptation being deployed in Australia and New Zealand, and we'll conclude with key findings and implications. At various points in development, this project has benefited from funding from U.S. government research grants. We also want to note that Dr. Pisani and I are part of Safeside Prevention, which receives fees for education and consultation. Suicide was the leading cause of death for youth in Australia from 2016 to 2018, and suicide is currently the second leading cause of death for youth in the United States. Organizations are using evidence-based practices and approaches to systematically prevent suicide. The vision is that consistent language and approach within and across settings can truly facilitate recovery, hope, and well-being for youth at risk and their families. Systematic approaches are making a difference. In Queensland, Australia, prevention-oriented risk formulation is an important pillar of the suicide prevention pathway implemented by Gold Coast Health. The pathway is a multi-level, comprehensive systems approach that integrates multiple best practices in addition to risk formulation. Its implementation achieved reductions in rates of repeated suicide attempts and deaths by suicide for consumers in Gold Coast Mental Health and Specialist Services. But there is a challenge. In workforce education for suicide prevention and human services, including youth-serving organizations, there are diverse clinical and non-clinical staff that serve diverse populations, and they do so in diverse locations, both in type of setting as well as in geographical spread. With that type of diversity, how do you sustainably train up a workforce in a common set of principles and practices? Through Dr. Pisani's research and practice experience at the University of Rochester, he developed two innovative approaches Safeside uses to address these challenges. First, a consistent framework of evidence-based and best practices in recovery-oriented suicide prevention. And second, a sustainable approach to workforce education that provides for initial learning and ongoing support and connection as skills are applied in their local context. Here's how we describe the framework in our workshops.
Almost any problem becomes more manageable if you have a framework for understanding and addressing it. This is true of suicide risk as well. We'll guide you through a framework that's organized around 4 core tasks that embody the best practices for supporting youth and adults at risk for suicide, no matter what your setting or role.
Connect, asking directly about suicide and the person's story and experience. The goal is to collaborate for safety and more than safety, towards recovery and well-being.
Assess involves gathering and synthesizing information with the purpose of understanding the person's experience and informing person-specific preventive actions. Respond covers those person-specific actions, plans, and resources for the person at risk as well as others in their lives. This includes how to work as a team to provide the best care and document that care.
Extend. For the people you serve, most of life happens when they aren't with you. Extending the impact of your care beyond the individual and beyond your setting can help you feel more confident that the responses and plans you develop together will hold up when unexpected stressors arise.
In-place learning, an approach that blends online learning with live connection and interaction. In-place includes 3 components: the in-place workshop, our community of practice and office hours, and refreshers and updates.
SafeSide's In-Place Learning Program is a next-generation expansion of the Commitment to Living, or CTL, workshop, the first brief training to demonstrate objectively rated improvement in assessment documentation. CTL was adapted online, tested, and enhanced with lived experience co-trainer, demonstrations, and a video-guided group learning approach that we previously validated with VHA substance use counselors. The resulting In-Place Learning Program is the subject of the evaluations in youth services organizations that we're discussing today, and its ongoing evaluations with veterans, primary care providers, and peer specialists.
Although Hillside has had a long-standing history of working with youth, individuals, and families to address suicide risk, we identified some unmet needs. We wanted to adopt and implement a universal workforce education program that could be delivered to diverse staff across a large geographic area. We also wanted to build a common language, knowledge base, and approach for suicide prevention across our system of care. However, as Sarah mentioned before, it can be quite challenging to implement and sustain organization-wide workforce education for a number of reasons. For us specifically, we have both clinical and non-clinical staff spread across a large geographic area that have a range of experience and training in responding to suicide concerns. So this makes it very difficult to find one training that's a good fit, that is appropriate and is transferable to the practice needs of such a diverse workforce. This brings us to the partnership between Hillside and SafeSide Prevention. Through both successful and not so successful project initiatives, we've learned that having a model to guide the process can make a really big difference with large-scale initiatives such as this one. So we use the EPIS framework shown on this slide to guide each stage of implementation from exploration through to sustainment. Briefly, we started in exploration by identifying the need, scanning for solutions, and evaluating the fit of the solution with our implementation context and setting. We adopted the solution, which was the SafeSide framework taught through In-Place Learning. We then collaborated together to adapt it to improve the fit of the solution specifically for our youth and family service settings. We convened the core implementation team and started pretty much by drafting a multi-level implementation plan. But the bulk of the effort in the initiative was really in the preparation phase.
Let's talk a little more about the adaptation. It included inserting custom language that was recorded in teaching to connect content to the participants. Hillside staff suggested scenarios for skills demonstrations similar to experiences they encountered in serving the youth from both clinical and non-clinical perspectives. The scripts were reviewed and refinements were made by Hillside and SafeSide staff. Real youth services staff recorded the demonstrations with youth actors, and then focus groups were held to ensure authenticity in the demonstrations to support learning transfer. Once the adapted program was completed, it was soft launched in 3 key sites at Hillside. From the soft launch, we developed the participant workbook to serve as a guide during and a resource after the workshop. Discussion and practice exercises were also improved to be more broadly applicable based on the roles present and reinforce key areas to enhance local application of concepts.
So as we talked about, during the preparation phase of the initiative, we developed a protocol for program evaluation. Program evaluations are useful in understanding the impact of the program or the initiative on key outcomes, but they are particularly useful in understanding the impact of adaptations. Is in-place learning effective when adapted to youth and family service settings? So the objectives of the program evaluation at Hillside were twofold. One, we wanted to evaluate the implementation of in-place learning on adoption and penetration or REACH outcomes. So adoption was defined by the number of programs who participated in in-place learning out of the total number of programs that were in scope. The target for this measure was 25 programs. REACH was defined as the number of staff who participated in in-place learning out of the total number of staff who were in scope. The target was approximately 1,200 staff. And the second part of the evaluation was to examine educational impact of in-place learning on outcomes including knowledge, self-efficacy, and transfer of learning. For this second part of the evaluation, there were 556 staff who participated. These outcomes are important for a couple of reasons. First, from previous research, we know that improved self-efficacy and transfer of learning are indicators of behavior change. In other words, staff are more likely to incorporate the learnings from education into practice, which is really the ultimate goal, to support positive outcomes for youth and families. Second, these measures were adapted from measures that have been used in past research and evaluation studies in the literature. So overall, findings from the program evaluation were quite positive. We measured adoption and penetration, or REACH, 1.5 years after the start of initial implementation. We wanted to make sure that we had enough time so that we could see program uptake and staff participating. We found that 100%, or 25 of the programs in scope, adopted in-place learning, and a large percentage of staff, 64%, participated in training, showing evidence of REACH. Results from the evaluation also indicated that in-place learning produced positive results in educational impact outcomes, including knowledge, self-efficacy, and transfer of learning. Specifically for self-efficacy, it increased for all staff who participated in the workshop, regardless of role, but we did see the largest increase for those in non-clinical roles. So not surprising, those in clinical roles had a higher self-efficacy prior to the training. So it's nice to see that completing the workshop strengthened their self-efficacy. And it's also encouraging to see that those in non-clinical roles had an even greater increase in self-efficacy. This gives us a good indication that we're making an impact where we really hope to from an organization-wide perspective by strengthening the ability of all staff regardless of role. Similar to self-efficacy, staff across roles, both clinical and non-clinical, found the training to be highly relevant to their jobs. When asked about the relevance of their training and its applicability to their jobs, the majority of staff agreed to strongly agreed, with each of the 7 questions shown on this slide. Across roles, 84% of staff agreed or strongly agreed that they would be able to use the training in their job. These are really important findings because, again, we know that the more transferable the learnings are from in-place, the more likely we are to see behavior change in suicide prevention. Moreover, these findings suggest that the adaptation of in-place learning for youth and family-serving programs was successful, that the adapted in-place learning was relevant and transferable to practice.
Now I'll talk about preliminary evaluations happening with youth serving sites in Australia and New Zealand. The goal was similar to what Laura presented. We looked to understand the outcomes and the impact of in-place workshop in youth serving organizations and sites in Australia and New Zealand, with a focus on learning transfer and impact. Right now I'll be reporting on results featuring 70 participants. The findings for learning transfer with staff from Australia and New Zealand are preliminarily quite similar and trending in the same direction as the findings that Laura just presented. 81% of staff indicated that the demonstrations presented are similar to those they encounter, and 97% indicated the teaching helped them feel more confident they could apply it. 100% of staff indicated the activities and exercises in the workshop helped them know how to apply their learning. Though the sample size is much smaller than the first evaluation, this initial data indicates responses for learning transfer are trending in the same positive direction. Staff have also been satisfied with the workshop, with 99% indicating they would recommend the in-place workshop to others in a similar role. 74% of staff have indicated that the workshop has impacted their perception of the role they have in suicide prevention. Through these 2 program evaluations, we've been able to validate using in-place learning, an innovative approach to sustainable workforce education in youth-serving settings. Our first program evaluation demonstrated increases in self-efficacy across all staff, with the largest gains for non-clinical staff. The workshop was perceived as relevant and transferable across diverse roles. The second program evaluation is ongoing, with preliminary results consistent with the first. This increases our confidence that the positive outcomes from the first program evaluation are being replicated, suggesting that our adaptation is generalizable across very diverse settings and locations.